health-related information on the following show provides general information only. Content presented on any show by any host or guest should not be substituted for a doctor's advice. Always consult your physician before beginning any new diet, exercise, or treatment program.
Are you one of those women who are told that you have a recurring UTI? You're given an antibiotic after antibiotic, and yet the burning, the urgency, the pressure, and the pain just keeps coming back. What if it was never an infection in the first place? What if the diagnosis was wrong and the treatment is actually making it worse? Welcome to Accelerated Health with Sara Banta, the podcast that gets straight to what works. I'm Sara, certified nutritionist, founder of Accelerated Health Products, and here we cut through the noise, bring you the real strategies, powerful supplements, natural solutions to help you detox, boost your energy, balance your body. So let's dive in. Oh my gosh, this topic, I've been wanting to cover it. We're diving in to one of the most frustrating and misunderstood issues in women's health. Women don't get attention. So many women are told they have recurring UTIs, and when reality, something completely might be going on. And joining me today, we have Dr. Milhouse, a board-certified urologist and pelvic floor specialist, and Heather Florio, a leading voice in women's health and microbiome education. Today, we are breaking down what most people, most women are missing and why so many are stuck in this cycle. Welcome, ladies. How are you today?
Doing good.
Thank you.
This topic hits home. Knock on wood, don't suffer from UTIs, recurring ones, but I've got family members that do. I've got best friends that do. And when you see that look on their face of, oh my God, here it comes, I need to run to the doctor because I know where it's going. It's so painful, and it's something women don't want to talk about. They don't talk to their husbands about. They feel like they're dirty down there. There's so many shameful feelings around it that they just go straight to the doctor. Doctor has 10 minutes with them, gives them an antibiotic, and they wonder why it keeps coming back. So I want to start with why are so many women being diagnosed with recurring UTIs?
So I am a board certified urologist, and I own my own practice in Chicago called Down There Urology. And recurrent UTIs are probably one of the top 3 things that I see in my practice, and I've been treating for over a decade. I also am somebody who actually suffers from recurrent UTIs personally. And the reality is, when it comes to female urethras, okay, so vagina owners, we are at higher risk for bacteria getting into our bladders. About 1 in 4 female urethras get recurrent UTIs. And recurrent UTIs are it's actually a pretty rigid definition. It is 3 or more symptomatic, you've got symptoms, culture proven or microbiology proven UTIs within a year, or 2 or more within 6 months. And I tell my patients that just because you have symptoms, if they're not substantiated with data, then we don't know if those are actually recurrent UTIs, because other things can be causing these symptoms. And just because there are some people who have constant bacteria in their urine, because guess what? Urine isn't actually sterile. But don't have symptoms. They never have symptoms. They're fine. It's like the bacteria are squatters. Those people should not be treated as recurrent UTIs either. Okay. So 3 or more culture proven symptomatic UTIs in a year, or 2 or more within 6 months. Because our urethras are short, we are more prone. There are other risk factors too. One big one is menopause and age and declining estrogen. So anything that causes declining estrogen, number one, menopause, but other things like lactating individuals, even some birth controls can lower your vaginal vulva estrogen. That increases your risk of UTIs because it changes your microbiome. And then penetration. So the act of penetrative sex is a risk factor. It's a very common risk factor that we see, especially early in or new sexual activity. It used to be called, I think, honeymoon cystitis. Like, newlywed woman now has recurrent UTIs because they're having all this new sex. So it doesn't mean that person's dirty, their partners are dirty. It's just the mechanism by which bacteria can get in.
You mentioned actually cultured and verified. I know that the people in my life that feel it coming on, they go to the doctor, they get a test, but they're leaving with a prescription and it hasn't been verified. They haven't gotten their results back. So can you talk about that?
Yes, I can. Okay, so we in medicine kind of have a knee-jerk response to UTIs. The knee-jerk response goes like this. Woman comes in complaining of any remotely UTI-like symptom. Oh, I have to go to the bathroom more often suddenly. Oh, it burns down. They don't even have to say it burns when they pee. Oh, it burns down there. Oh, I have cloudy urine or funny smelly urine. You go to your, urgent care, ER, maybe even your primary care or whatever. You are most likely going to walk out of there with a prescription in hand. Antibiotics have like revolutionized medicine since they were founded. Okay. They're great drugs. We have overused them, however, okay. And this knee-jerk antibiotic prescription is something that doctors are used to doing and patients are honestly used to receiving. Okay, it's a two-way street. Yeah. The patient going in is expecting to walk out with something. The doctor's like, I got to make the patient feel better. Let me give them something. Okay, the large part of this is just cultural and kind of like this is how it's been done. We, however, need to change that and adopt a antibiotic stewardship because we are creating superbugs that are making it harder to treat normal UTIs. I have seen multiple examples of patients who have a UTI that now nothing we have on the market, oral pill, works for this organ, for their UTI because it's resistant to all the options. And so now they have to get IV infusions. And it's because of overuse of UTI, antibiotics. Is well documented in medicine. We prescribe too many antibiotics for too long. And I don't practice medicine this way. This is why I feel very strongly about that question. I don't want the patient to suffer. There are ways we can go about this without suffering involved, but I'm going to be an antibiotic steward. Yeah.
And I'll kind of add to that a little bit. One of the biggest things that I see that comes over actually from the UK is a theory that is not embedded in science, but they think is embedded in their bladder. And that is the idea of embedded bacteria within their bladder. And what we are seeing that came over from the UK is not just the standard go in, get the dipstick test, get your culture, things like that, and get handed some antibiotics, but we're actually seeing where they're actually being prescribed high doses of antibiotics by the doctors that necessarily prescribe to this theory in long term. And this was a theory that was developed by a UK clinician, and as a result has made it over here to the US. And there are several doctors that very much prescribe to this theory. And this is leading to very sick women, especially women, in which they're doing these high dose antibiotics. They're not just killing, and making themselves antibiotic resistant. They're killing their gut microbiome, their vaginal microbiome. They're doing a disservice to their entire body. And unfortunately, this has become a thing that has been highly talked about as a result of these diagnostic tests, which they can go do themselves. They get higher RAN, and then as a result think that they have an embedded UTI and that they need to take these high dose antibiotics.
And I want to touch on the microbiome. Yes, you're taking an antibiotic for one localized area, but the antibiotics is killing all the good stuff everywhere. So can you touch on the side effects of taking antibiotics in general?
Yeah. Heather kind of started that conversation. So because it can kill all the good bacteria. That's why I said good in the middle of everything. It can kill the bad and good. You can get diarrhea. You can get yeast infections. I've had a patient get thrush, which is candida on your tongue, a form of a yeast infection. You can get something called C. diff, which is an infected diarrhea, which has to be treated with a different antibiotic regimen.
Right.
You can obviously get resistant organisms. So antibiotics are not benign. These are common enough. I mean, I see this all the time. Patients like, oh yeah, every time I get an antibiotic, I get a yeast infection too. So now, like, what happens when we get diflucan resistant yeast infections? Because that's coming. I know.
Yeah. The cycle.
Yeah. That's another podcast, like another subject for another time. But anyway, I rarely see that long-term or more antibiotics is rarely the treatment for UTI symptoms. When it's not like a severe infection, like a blood infection or bone. You see what I'm saying? I rarely see that more longer is the best, long-term solution. That is, there is a lot of embedded UTIs. Just going back to that is kind of like a new buzzword that patients often will bring up. And speaking to my infectious disease colleagues, at least around where I practice medicine, it has not been something that has been accepted within a large majority of the U.S. medical institutions. Like, okay, what does that clinically mean? And so it's not something that I'm happy. It's not something that we have truly subscribed to this more longer antibiotic regimen, because again, it likely is not going to be the best solution.
Right. I mean, just from hearsay, I've got a friend that is very much into her health and eats all the right things, does all the right things. She knows antibiotics are horrible for her. But when she gets a UTI, she's the person that has that fear in her eyes and gets an antibiotic. And, this last time, a week later, she's like, I feel horrible. I feel like crap. My gut is all wrecked. I'm constipated. And she goes, I know it's the antibiotic that I took. And so the symptoms are pretty apparent. I mean, even a family member who is an older woman, she will take it and she'll go, gosh, I just feel depressed. I'm like, well, yeah, it's going to affect your mood. I mean, it is doing so much damage. So with that being said, okay, so there's a lot of misdiagnoses. So we're giving antibiotics for a UTI that wasn't really a UTI. What conditions are mimicking UTIs that people should be aware of that they might be suffering from instead of an actual UTI?
Well, let me say this. Antibiotics can be great for a lot of people with UTIs. I mean, everything has side effects, but the overuse of antibiotics is a huge huge problem. First of all, part of this knee-jerk thing is patients have symptoms. The testing, cultures or PCR testing, you can never know the day you come in whether you have a culture-proven UTI. What patients are told is you have a UTI, but it's based on preliminary tests. It's based on dipsticks and urine microscopy, which are not the same as cultures or PCR testing. And so the patient believes they tested my urine, I have a UTI, thus I need an antibiotic. But what there really is happening is they did a preliminary test. It maybe suggested they had a UTI. Here I'm giving you antibiotics anyway. And maybe they send it off. Maybe they don't. I've seen lots of examples where they don't. Okay. So then the patient comes to see somebody like me after 3, 4, 5, 6 rounds of this. And I'm like, okay, what are your cultures? And then they hand me a bunch of preliminary tests. And I'm like, these are not cultures. The patient doesn't know this. These don't tell me much of anything. Okay. So we need to stop dumbing it down for patients. Okay. We need to educate them on this. I spend less than 5 minutes educating patients on this, and they're like, oh my goodness, thank you.
Mhm.
So we need to be led by data every single episode. Okay. And we need to try to treat the symptoms, the burning, the frequency, the whatevers, as best as we can, and wait for that data when we can before we give an antibiotic prescription. Okay, there are other medications that can help you feel better that don't mean an antibiotic, other lifestyle changes that can help you feel better that don't mean an antibiotic, and we can safely wait for that to finalize before we give you. But to answer your question, what are the other conditions that can mimic? Well, something called genital urinary syndrome of menopause, which is where your vulva and vagina lack estrogen and therefore become a hostile place. And that includes your urethra opening, because guess what? Your urethra opening and inside your bladder have estrogen receptors. Okay. And when estrogen is low, it doesn't really like it. It tends to increase burning, it tends to increase frequency and urge. So patients who have this genital urinary syndrome of menopause, or GSM, can really very much look like a UTI patient. They'll come in saying it kind of burns down there. With, when I urinate, it might burn worse, but sometimes I just burn even when I'm not urinating. They'll say I have a constant awareness of my vulva or my urethra, or just this new constant urge or urgency. Okay, sounds like a UTI to me. That's one. Another thing is an entity called interstitial cystitis, which is a chronic bladder pain syndrome that is not infectious. And and can be a range of symptoms from bladder pain, bladder frequency, all the way to like just vaginal pain, pelvic pain, those type of things, or combination. You can have another pathology in your bladder that isn't a UTI. You could have a bladder stone that's caused it, if it's big enough, it may cause you to feel like you got to pee more often. You may see blood in your urine. If you have a bladder tumor, that could be a cause of blood in the urine. Usually a bladder tumor doesn't cause pain, but it can cause blood in the urine. And one thing we used to see is female with blood in the urine was knee-jerk treated as a UTI, knee-jerk treated, and not properly examined for potentially other things, not confirmed UTI. And it led to the reality that female patients with bladder cancer are more likely to have a delay in diagnosis because they're treated for a long time as, UTI. So there are other things that we need to make sure don't exist or aren't part of it, especially when patient symptoms aren't getting better with antibiotic treatment, especially if cultures are coming back negative.
Yeah, I can end up with anywhere from, 10 years to 30 years. I've been specifically interstitial cystitis. I've been working with interstitial cystitis patients for over 33 years now. And
Can I just say this? Thank you for doing that work.
Thank you.
Thank you for doing that work. Yeah.
Millions of men and women, and they're suffering, and they're suffering. And, Dr. Milhouse mentioned the GSM. A lot of the times, in a lot of cases, this is where this becomes cyclical diagnosis, where we're ending up all over the place, because interstitial cystitis is a diagnosis of exclusion. So we're trying to figure out, especially for women, where we have so much going on in our pelvic region, and we're trying to identify what is going on in the pelvic region, whereas in other parts of the world, we're diagnosing only via cystoscopy. We're only diagnosing via true, that's where they put a camera up your urethra. They're looking in the bladder. They're looking at your bladder wall, and they're looking for true bladder wall impact, whether it's ulcerated, severely inflamed. And then when they see this, then they truly get a diagnosis of interstitial cystitis. In the rest of the world, in the United States, it's diagnosed via exclusion. And this is where a lot of people end up cyclically in that environment of either chronic UTIs, but typically if you have interstitial cystitis, what happens is you get that dipstick test, they hand you the antibiotics, you go back, you get the culture back, and then that culture is negative for any type of bacteria, because interstitial cystitis isn't about bacterial infections. It is a true degradation of the lining of the bladder. But then that can also overlap with the similar GSM symptoms, because your bladder lining, your urothelial cell layer of your bladder is degrading during menopause if you're not on HRT. And so as a result, we have a lot of overlap that happens in this area. And for us with interstitial cystitis patients, the road to diagnosis is even much longer than the chronic UTI. They usually end up in the chronic UTI area before an chronic antibiotic overusage. Before they even get a true diagnosis, they might have overlapping symptoms of endometriosis, uterine fibroids, PCOS, all kinds of other things going on. There are a lot of comorbidities related to other autoimmune conditions like Sjogren's disease, dealing with fibromyalgia. There are a lot of fibromyalgia patients. So there's a lot of overlap that can happen that makes diagnosis very, very, very difficult. And women end up in this environment. And I think by increasing our research within the pelvic region, within these pelvic conditions, so that all of this doesn't become a diagnosis of exclusion, where we have urologists like Dr. Milhouse, and then we have urogynes that are looking maybe between the bladder, but they're also looking at the endometriosis, the uterine fibroids. They're looking at a complexity, and then they're saying, but the problem is we have nothing for the endometriosis. We have nothing, other than birth control and hysterectomy really right now. But when we talk about a lot of these different conditions that relate in the pelvic region. And so they end up in this horrible cyclical environment. And we really need to do justice to the research especially for women, to get us down that path. Dr. Milhouse and the great group of women are doing all this research related to GSM and looking at these symptoms. And we've made headway with menopause, and I love it. And now the question becomes, we see a high rate of diagnosis of interstitial cystitis in that post-menopausal age. So what happens when we add that, and you might know a little bit more here, Dr. Milhouse, but when we start adding that at a post-menopausal stage, you're already in your 60s, you're already, you've already had that bladder lining degraded. And so what happens when you add HRT at that point? And this is where the research really needs to be done. What happens to the bladder lining? Can we improve the symptoms? And so I think it all gets down to the root of needing to be researched, so that we don't end up in this cyclical environment of all these overlapping conditions, and they end up in this environment of 10 to 30 years to diagnosis.
Oh my gosh.
Sorry to interrupt, Sarah. A lot there that is very true. I want to touch on a couple things just to clarify. Number one, GSM, that changes that happen, is not something that just affects you when you're in the menopause transition area. It will continue and progress until you die. So it is progressive. Number two, HRT, systemic HRT, does not treat GSM. So just because you're on systemic HRT, you may have these symptoms still and be like, well, what? I thought I'm taking hormones.
Right.
What's the deal? The treatment for GSM is vaginal hormones, and you can add that to HRT. Or if you can't get HRT for other reasons, you can safely get vaginal hormones. Again, probably another podcast for another day, but I just wanted to make sure our viewers are left with that to clarify. Number three, yes, currently in the United States, the American Urologic Association, we don't believe that IC can be absolutely diagnosed with a cystoscopy, looking inside your bladder, because we know that there are plenty of IC patients that have normal looking bladders, at least to our naked eye. Okay. I scope a lot of bladder pain patients, and a lot of them have normal looking bladders. In fact, the ones that don't, I'm kind of happy, because they actually have probably a slightly better prognosis because now there's like an ulcer that I can treat or something. Okay.
Yeah.
But it doesn't mean because you have a normal looking bladder on cystoscopy that you couldn't be dealing with that. And then lastly, pelvic floor dysfunction, pelvic floor. We talked a lot about IC, GSM, endometriosis. Most of these people also have pelvic floor dysfunction or pelvic floor dysfunction separately. And pelvic floor therapy is a large part of this conversation as well.
And that becomes really the bladder pain syndrome group. So I was part of the consensus with the ESSEC committee, that is the worldwide organization that defines interstitial cystitis. And interstitial cystitis and bladder pain syndrome are really going to become two distinct conditions. So when you talk about cystoscopy and having a completely clear bladder, that becomes that bladder pain syndrome. And that is really a complexity where like pelvic floor physical therapy, pelvic floor dysfunction can fall into. 88% resolved with pelvic floor physical therapy and clinical research with that. We partnered with UCLA, and Dr. Lenore Ackerman there did a study in which she was able to phenotype out and find 3 distinct categories. And so really we have this bladder-centric group that is truly, and I think this is where the definition is really changing, and this is really recent, that just happened last year as part of the consensus at Wake Forest University, where we were part of this group trying to decide this definition. This is actually already decided at the ESSEC level, and worldwide they're using the nomenclature interstitial cystitis to specifically deal with true bladder wall impact. So that is your ulcerated, inflamed bladder with certain levels of bladder capacity. And then you have your bladder pain syndrome, which is going to be your true, this is going to be your more non-specific. So this is going to be when you diagnose via cystoscopy and you see no bladder wall impact, but they have the symptoms that mimic interstitial cystitis. And this is where the disservice of research has really been done to interstitial cystitis patients, because we can't get to the etiology. We can't understand, because we have the waters muddied a little bit by diagnosis of exclusion. So as a result, you see that bladder pain syndrome group is more like the pelvic floor physical therapy, non-specific neuralgia, other overlapping conditions, other comorbidities that might lead into that particular condition. And so that's where you really have a distinction of really 2 conditions. And you're going to see this come out more and more. And it's actually going to be talked about at AUA here in just a few weeks in DC, where they will actually be having an entire session where we'll be talking specifically about this and talking about the fact that these are 2 completely different conditions. There is interstitial cystitis, and then there is that can end in end bladder stage. And then there is true actual bladder pain syndrome, which is that more complexity of unknowns of kind of where we put those that have those symptoms, but it's more related to other overlapping conditions, non-specific neuralgia and or pelvic floor dysfunction.
Oh my gosh, so detailed and overwhelming. There's so much there. Yeah. Number one, I did not realize that the UTIs were connected to a loss of estrogen. That's an aha moment for me. My audience is always looking for root cause solutions and prevention, right? So that we don't get to that point. What do you recommend? Number one, you had mentioned you have ways to help with the pain until the diagnosis is confirmed. For those women out there that are just so anxious to get that antibiotic to take care of the pain, what would you give them or tell them to do in that waiting period until their diagnosis is confirmed?
I have a pretty good regimen for my recurrent UTI patients. Number one, I put a standing urine culture order. And so because that panic is real. When you have those UTI symptoms, I know because I have recurrent UTIs, the panic is real. You're like, oh my God, I already know what's coming and it's going to be hell. And I'm, in the middle of my, at work or something.
Yeah.
So, but before they do that, I tell them, listen, drink tons of water, water is good. I know it seems maybe initially counterintuitive, like, no, that's going to make me pee more and it hurts to pee. No, it's going to help flush out.
Yeah.
That's the time you need to put away the bladder irritants. If you know that you're a coffee drinker every day or tea drinker or soda, when you have those symptoms, you got to cut those out, at least during that time, because that is pouring gasoline. Okay. That also is the time that I liberally will use and prescribe phenazoparadine, or other like bladder soother, medicinals. This is a medicine that can be prescription or over the counter. And my recurrent UTI patients are armed with it ahead of time so that they don't have that panic because they have something. And that helps a tremendous amount of them feel better, because really, honestly, what are UTIs about? They're about hurting. They are being like, just constantly in the bathroom. Okay. So as long as those symptoms are better and controlled, like, fine, I can go about my day. So that helps a tremendous amount of people. I'm not saying it's going to help everybody 100%. Nothing is 100% for everybody, but this helps a lot. Some people will use supplements and say, yeah, this helps me feel better when I have UTIs, have at it. But we do cultures, we do all those things. We wait for the cultures to come back. When we look at the result. Yeah.
And what about prevention? Here you've got your patient that has these recurring UTIs, has been on antibiotics, and they're like, I'm desperate. I don't want another one to come back. What can I do for prevention?
Well, let me just tell you this. If you are 40 and above, you are likely in perimenopause or menopause or postmenopause. Just assume. And if you are getting recurrent UTIs, your best root cause prevention strategy is vaginal hormones, vaginal estrogen, period. Okay. You want something root cause, it can't get more root cause than that. Okay. That is a prescription. It is safe. It is safe to use if you've had breast cancer. It is safe to use if you smoke. It is safe to use if you have a clotting disorder. It's safe to use if you've had a blood clot. It's safe to use if you've had a heart attack. It's safe to use an old grandma who has dementia. Okay, it is safe. It's safe to use if you're lactating. Okay, you are automatically probably at higher risk. I am 43. The moment I turned 40, that's when I started getting recurrent UTIs. I've been having sex with the same person since I was like 26. Okay, same amount of sex, probably less now that I'm 43. But so I knew what the problem was. So vaginal estrogen, vaginal hormones is your root cause prevention. And its studies show decreases UTI by half. It decreases hospitalizations by more than that. It decreases urosepsis. I will, when I die, my tombstone will say vaginal estrogen saves lives, because it really does.
I love it. And what about diet and stress?
Yeah, Heather, do you want to take that on?
Yeah, so diet can definitely play a huge role when it comes to interstitial cystitis, especially, and even those that have GSM, where necessarily their bladder is degraded to the point where their urothelial cell is so deficient within their bladder. Imagine anything that's passing through there, like Dr. Milhouse mentioned, get rid of the coffee. That's because anything that passes through there is going to be like battery acid on a wound. And so you have to think about, as you start thinking about your diet, feed yourself what it needs, feed the whole foods that your body necessarily needs, because that also contributes to the good bacteria in your body. But at the same time, you can also test which foods you can actually tolerate. Think about acidity as a bad thing in a sense when it comes to foods and diet when you're having these symptoms, because it exacerbates, especially if you have a degraded bladder lining like with GSM or with interstitial cystitis. it literally will cause that. But at the same time, you want to think about nutrition in a sense. We have supplements at Desert Harvest, where as my company, that we provide specifically to help with these nutritional deficiencies. But the best thing that you can do is whole foods. I always say the easiest thing, where we like easy. I have a multivitamin. Yes, I do. It's to get to that root cause. If you're already so deficient and you're not eating, I had one interstitial cystitis patient that said, actually a lot more than one, that are like, I'll only eat foods that are white. And so they're like potatoes, pasta, like anything that is white. And I'm all like, the nutritional deficiency there in thinking about how you eat. There are amazing nutritionists out there, and especially ones that focus on the bladder, that can help guide you, and also ones that focus on menopause, that can help guide you through the process of how to eat for your body in a healthy manner. And at the same time, supplementation is great, but that isn't the be all end all when it comes to necessarily feeding your body back what it needs. It is about the foods that you feed it, but at the same time, also thinking about that acidity. And then when you think about like the supplements that are available out there, and is the standard over the counter that everybody goes to is D-Mannose. But in clinical research, D-Mannose only binds to one bacteria. And this isn't for an active infection. This is as a preventative. But it only binds in clinical research to E. coli bacteria. That's it. E. coli accounts for about 80% of UTIs, bacteria, uropathogens, but we have another 20%. And that's where you get a lot of the recurrent UTIs in a lot of cases, because you see these pathogens that maybe, like Dr. Milhouse alluded to, the antibiotics aren't necessarily working for anymore. They're constantly in that cyclical environment of that. We did just recently create, it's actually sourced from the heather plant, the Calluna vulgaris. And in our clinical research that we did, we were able to find that 3 pathogens we were able to bind to, not just one with the D-Mannose. Mannose is naturally in aloe vera, which we utilize. We have double-blind placebo-controlled studies. It's currently undergoing FDA drug trials for interstitial cystitis right now. And we've been utilizing that product for over 33 years. There are mannose molecules naturally in aloe vera. So, if you're already taking that product, you're getting the mannose molecules. But if you're talking about the other pathogens, so in the case of ironically, the heather plant, not because of my name, it's called Heather's UTI Defense. It binds to E. coli, E. fascialis, and P. vulgaris. And we're actually studying 2 other pathogens at Oxford right now that have potential to potentially also cover this broad spectrum with Heather's UTI Defense. And this would flush that out. Again, preventative, not active infection, but preventative. And so we're always trying to look at what would work and what is out there and what is not. Just understand the science. So you're going to be thrown so many things on social media, so many ideas of what'll do this and what'll do that. The supplement industry is an unregulated industry. Look at the science of what is out there. Talk to your clinicians like Dr. Milhouse, because they're going to know, what you should and shouldn't be taking. They're going to know what drugs you shouldn't and shouldn't be taking with those said supplements. And Dr. Milhouse said, vaginal estrogen is huge first thing you should go to if you're in menopausal, perimenopausal on, like that's the first thing that you should be looking at. Definitely.
Oh my gosh.
I just want to add, when it comes to cranberry, because that's going to come up.
Yeah.
We don't touch on that.
Yeah.
Your viewers are going to be like, what about that? There's a lot of cranberry supplements out there. A lot of them, I'm sorry, I'm going to step on some toes, are useless. You're wasting your money. What we have found in the moderate amount of evidence is that cranberry supplements may work, but must contain a minimum 36 milligrams of proanthocyanidins, or PACs. That will be something that is clearly on the label if they have it. I tell my patients, it is not going to be like where you got to squint and look at the back of the bottle, because that supplement wants to stand out in that manner. So if your Cranberry supplement doesn't say 36 milligrams or more of PAC or proanthocyanidins, then you need to change it up.
Yeah. And again, that's the mannose molecules that are in the Cranberry supplement. But no, if you are an interstitial cystitis patient, that will actually cause you to flare in a lot of cases. So we do, like, Cranberry is a go-to in a lot of cases, but in the case of an actual interstitial cystitis patient, it is a no-go. And it's one of those things that is on the Interstitial Cystitis Association's no-go list. So just be careful there when you're looking at Cranberry, just for that reason. But again, same thing, same mannose type molecules that are binding to that E. coli bacteria.
Oh my gosh. So I drink aloe vera juice every day. So maybe this is why I don't get UTIs. But I have to ask a side question, and I can't believe we're out of time. I do suffer from E. coli infections. They end up in my gut or my liver, not necessarily in my urinary tract. Would D-Mannose help kill the E. coli in any part of my body?
It's not looking to kill it, it's looking to flush it out of your system. So yes, when you're talking about your entire system, it's going to bind, but it's not meant to act for an active infection in your body. It is more of a preventative. It's not meant to function in that way. And aloe vera juice, like you mentioned, is great, but the thing is that an aloe vera plant is almost 99% water.
Right.
So it is very hard, and you have to use, when it comes to the bladder, again, aloe vera juices can be problematic because there's only two ways to preserve them. There is either bladder irritating preservatives like citric acid and other things like that, or pasteurization. And then once you pasteurize it, you've just killed all the active nutrients and you've just paid for very expensive water. And a lot of the juices out there either utilize one of these two methods. So that becomes problematic for a bladder patient. But we know that you are getting there's over 200 nutrients in the aloe vera plant. 75 of them are active. There's active enzymes, antimicrobials, antifungals, antibacterials. You've got this entire amazing complex of nutrients in the aloe vera plant, but it's important that you look at because like you'll see a lot of inner leaf gel that is scraping above the anthraquinones when you open the leaf, and that's a slimy, thin yellow layer. Those are carcinogenic long term. So those are meant to be temporary aids. So a lot of companies, because the FDA allows 10 parts per million, will just scrape above the anthraquinones and just to capture just that part. And so it's really important when you think about the aloe vera plant, you think about where it came from, how it's being used. Desert Harvest, we utilize a patented process. So yeah, we start with the aloe vera plant, but what we create in the SSAV is not in the end what you start with or what you find in health food source supplements. That's why it's undergoing FDA drug trials, because we have so much 33 years of clinical research showing that it's safe for long-term use and in high doses, where a lot of aloe veras aren't necessarily, or if they are, that's because they're not so concentrated. Ours takes roughly 89 full-grown Aloe barbadendis Miller leaves to make one. Those are the big 3 foot, 4 foot wide, to make one of our 180 capsule bottles.
Oh my gosh. This is a perfect example of people trying to do the right thing and it backfiring, right? Because people listening, people drinking aloe vera juice, people taking their cranberry capsules, they're trying to do the right thing and it's backfiring, making them worse. Ladies, this has been phenomenal. You have shed so much light on someone who doesn't even get UTIs. But I will be sharing this with all of my close friends and family, among everyone else, because this is such an important topic and it's so misunderstood. So thank you so much. Can you tell people where they can work with you, how they can follow you, and just know what you're doing?
Yeah, so thank you, Heather. I am on social media at Dr. Milhouse. That's Milhouse with one L. On Instagram. If you forget that, just remember your favorite urologist. If you put that in the search, you'll get me. That's the same for you for TikTok. Your favorite urologist, you'll get me. Same thing for YouTube. If you put your favorite urologist, you'll get me. My practice is Down There Urology. So if you're somebody who's like, oh my goodness, I've never met a urologist like this. This is the type of urologist I need. Please, I am accepting new patients. My practice is located in Chicago. I do virtual visits as well as in-person visits. Down There Urology, super easy name to remember because everybody says Down There. Yeah.
Perfect. And mine is at Florio on Instagram. And if you FLORIO, all that Italian fun. And then, but website is desertharvest.com. Please definitely check us out. Check out our products. And you're always welcome to message me for questions.
Amazing. Well, thank you so much, ladies. This was definitely eye-opening, and I know people are going to just dive into this information. So thanks again for joining us.
Thank you, Sarah.
Thank you.
All right. I wanted to step in here at the end for a minute because this is where everything starts to connect. I learned so much. When the body's inflamed, we talked about itises during this podcast. Anything itis is inflammation. So you want to lower that inflammation. When the microbiome's disrupted, the detox pathways are sluggish, you don't just see it in one place. I talk about the liver all the time. I talk about the gut all the time. We don't talk about the urinary tract a lot. But this is why so many women are stuck. They're chasing their symptoms instead of supporting the body at a cellular level. You want to give your cells the energy, the ATP, to fight off of these symptoms, to lower the inflammation, and so that you're not getting misdiagnoses left and right. So I wanted to touch on a few basic supplements that boost that immune system, help increase that mitochondria and cellular energy. And number one, I have to pause for a second because something that most people have never been told, methylene blue isn't just for the brain or energy. It's got a unique relationship with the urinary tract. That's why your pee is blue. It's going down the urinary tract. It concentrates in the urinary tract, and it literally is an antiviral, antibacterial. It passes through the kidneys and the bladder. So it's been used for urinary tract support. It also helps balance the microbial environment in the bladder, reduces inflammation and irritation, supports the mitochondria. It is an anti-ager. All of the peptide gurus out there are throwing in methylene blue alongside of it because of its anti-aging properties. But it's also helping with oxygen utilization in the tissues that are inflamed or stressed. And this is where accelerated methylene blue is hands down a go-to. I put it in my morning drink every single day. Gives me great energy too. So that's number one. Number two, acceleradine iodine. Iodine is foundational. It is the easiest way to increase your cellular energy, that ATP, in the mitochondria. It detoxes the halogens, the fluoride, bromide, chlorine that are disrupting your detox, lowering your immune system. It's giving your thyroid what it needs to function. It is the 4 and the 3 in your thyroid hormones, T4 and T3. So yes, it helps with fatty oxidation and energy and body temperature, but it also is antiviral, antibacterial. Doesn't matter where it is. It goes everywhere. It is not just for your thyroid. The third one, I can't say it on this podcast. So you're going to have to DM me below to know what it is, but it is a natural antiviral, antibacterial, anti-inflammatory, and it's been known for thousands of years to do so. It is the supplement that started my business because it helped my son come out of his leukemia. It supports the immune system's resilience. It gives you that deep battery pack for your immune system. So when you combine these, you're actually supporting the body so it knows how to heal. Your body's the miracle, right? This is why this conversation matters so much today, is when you understand what's really going on, you won't necessarily have to just focus on one area of the body. Let's look at the root cause. Let's look at the whole body as a complicated system that works together. Because you take that antibiotic for your UTI, it's going to affect your brain, your gut, your digestion, your liver, all of it. Thanks for tuning in. And before you leave, let me know what sparked a question in you. I have so many more questions myself. Did something I say or the lady say hit home? Leave a comment below. And if you haven't joined my free group coaching on Telegram, do so today. It's a place where you get your questions answered 7 days a week, and you're a part of an amazing supportive community. All of our articles, my free group coaching, the supplements we talked about, you can find them at sarabantahealth.com or acceleratedhealthproducts.com. You can use coupon code podcast10 on your first order. And most of you listen every week, but you still haven't subscribed. Click that button below so you're notified when all of the podcasts are released. They can be found on Spotify, Apple, YouTube, E360, iHeartRadio, Amazon, Roku, and over 100 other platforms. And remember, I drop a new podcast every Monday, Wednesday, and Friday. So join me next time for more ways to unlock your health potential.